Good evening to all. My name is Mihaela Budimski-Soldat, and it is my honor to open this conference. Let me introduce myself in a few words. I am a board member of Serbian Resuscitation Council and serve as secretary of journal Resuscitatio Balkanica. I would like to welcome you from Subotica, from the northern town in Serbia. Here, in my town, we had the first registered SARS-CoV-19 case in Serbia during the pandemic, which shook up the world in the last months. This was one of the reasons why we decided to open this event from Subotica. Another reason that we are starting from here is that my town has been hosting the central events and public activities for the World Restart a Heart Day for many years. The strong message of World Restart a Heart Day, initiated by the European Resuscitation Council, is that the society saves lives, including children, citizens and community. It is based on an open call to all citizens of the community to act actively wherever cardiac arrest occurs and perform CPR on scene. Now, we can see Davor Stefanik, our Olympic champion in wrestling from Rio, while performing CPR among citizens and strongly support and promote our National Resuscitation Council's World Restart a Heart Day activities. As a national council, we put huge efforts and hard work in creating awareness to help when needed, especially among children and also all citizens. Recently, the fear of a virus and infection creating huge question marks and challenges related to life-saving first aid maneuvers, BLS and CPR. The preparedness and readiness to provide individual help to perform compressions and eventual ventilations was challenged the most by pandemics. Today, we might state that the first wave of COVID-19 is behind us. However, the virus is still very much around us, perhaps not as detectable as it used to be, but is for sure occupying a good part of our minds. The second wave of COVID-19 pandemics is foreseen in autumn. Today, the life is coming back to normal all over Serbia. At least, this is how it appears to be. Taking this into account, we organized this meeting with the aim to try to discuss and share thoughts, experiences and facts about resuscitation and pandemics. Tonight, our lead host and moderator of this panel discussion will be Dr. Violeta Rafai, President of Serbian Resuscitation Council, a great scientist, one of the lead experts of resuscitation medicine in Serbia. She is dedicated ERC ambassador for many years in education, courses development and implementation all over the world.
Okay, thank you so very much for that. And I would like to say then in this mode as well, as you can hear me. Good evening, Mihaela, and thank you for the very nice introduction and kind words. So Mihaela is in Subotica with our IT team who are taking care of the smooth streaming and other deep technical details. So greeting to all of them. The logistics, forwarding the questions and the support in starting our event is in hands of Dr. Fischer and Dr. Lazic at our Novi Sad studio. Good evening, Sandra and Zlatko.
Good evening. Good evening to all and good evening to you, Violeta. We already received quite a number of various interesting questions, and we currently have 660 something people with us right now streaming. Just to repeat it quickly, that all followers can communicate their questions by email and from the live streaming page live.resuscitation.org.rs. Thank you.
Thank you, Sandra. I'm just trying to unmute myself when it's required. It is my honor and privilege to welcome and introduce our expert panelists tonight. Professor Leo Bossard, Professor Emeritus, University of Antwerp, Belgium, one of the founding fathers of the European Resuscitation Council, who devoted his career to resuscitation. Leo have a specific, very strategic way of working and thinking, what is an eternal inspiration for all of us for many, many years. And Leo is a resuscitation giant. Welcome, Leo.
Thank you. And I'm supposed to take over now?
Leo, I would like to introduce all other panelists as
well.
well.
Yeah, okay.
And then we will start.
Hi.
That is okay with all of us. Thank you very much. Okay. Professor Bernd Böttiger, Director of Science and Research, European Resuscitation Council, Chairman of the German Resuscitation Council, Professor and Head of the Department of Anesthesiology and Intensive Care Medicine at University Hospital of Cologne. Professor Böttiger is also specialized in emergency medicine, and his research focus is on resuscitation, especially bystander CPR, kits save lives, and cerebral reperfusion. Being an exceptional leader, mentor, and visionary, we all learn from Bernd how to think big. Welcome, Bernd.
Thank you very much. Welcome.
Professor Koen Monsieurs, chair-elect of the European Resuscitation Council, Professor of Emergency Medicine, University of Antwerp, Belgium. Koen is an exceptional thinker. The way he acts and speaks always motivates people around. A great mentor, Koen is. Welcome, Koen.
Thank you so much, Violetta, for having me tonight. Thanks.
Thank you. Professor Şule Akin, Başkent University, Faculty of Medicine, Department of Anesthesiology and Reanimation, Adana, Turkey, President of the Turkish Resuscitation Council. Welcome, Şule.
Thank you very much, Violetta.
Thank you. Professor Diana Cimpuescu, Head of Emergency Department and Pre-Hospital Emergency Medical Service, University County Hospital, Iași, Romania. Chair of the Specialty Committee in Emergency Medicine and Disaster at Ministry of Health and Romanian College of Physicians. Chair of Pre-Hospital Section USM, Deputy of the Romanian Resuscitation Council. Welcome, Diana. Docent Artyom Kuzovlev, Head of the Vladimir Nagovsky Research Institute of General Reanimatology, Moscow, Russian Federation, ERCGIC Task Force member. Welcome, Artyom.
Thank you.
Dr. Federico Semeraro, Consultant in Anesthesia and Intensive Care Department of Anesthesia, Intensive Care and Emergency Medical Services, Maggiore Hospital, Bologna, Italy. ERC Science and Education Committee Basic Life Support Co-Chair. Welcome, Federico.
Hello to everybody.
Dr. Anatoly Trular, Consultant in Anesthesiology and Emergency Medicine in the Emergency Medical Service of the Hradec-Králové region and Department of Anesthesiology and Intensive Care Medicine, University Hospital, Hradec-Králové, Czech Republic. Anatoly is a medical director of the regional EMS and the lead physician at one of the helicopter emergency medical service bases in the country. In 2010, Anatoly became chairman of the Czech Resuscitation Council. Czech Resuscitation Council, and since 2011, he is a board member of the Czech Society of Emergency and Disaster Medicine. I promoted you a bit. Welcome.
Thank you very much, Violetta, and thank you for introduction.
Thank you. Jose Giraldo, Emergency Medical Service out of hospital care, Barcelona, Spain. Jose is also a European Resuscitation Council BLS Science and Education Committee member. Welcome, Jose.
Thank you, Violetta.
Dr. Ferenc Sári, Norrland University, Sweden, Director of Emergency Medicine, GIC Task Force Chair. Welcome, Ferenc.
Thank you, Violetta. Good evening, everyone.
Good evening. Walter Renier, Chair of the Belgian Resuscitation Council and ERC Basic Life Support Science and Education Committee member. Thank you to all for being here with us. And it is my greatest honor to serve as a moderator tonight for our panel discussion with the most eminent experts in resuscitation medicine. I'm currently in Budapest, Hungary, and I faced the global pandemics in the United States. And upon my quite challenging arrival back to Europe, I find myself surrounded by so-called paralyzed countries, lockdown borders, and quarantine. And I am here with my parents, aged well over 70, and working from nowadays so popular home office. So wherever we all are affected by this situation. And all the above highlighted created the vision and the idea to organize this meeting on behalf of the Serbian Resuscitation Council and to share experiences, impressions, and thoughts, and some facts about ethical and other dilemmas about the resuscitation in pandemics. Personally, I find a lot of issues concerning, and for the first time in our contemporary history, we faced with challenges created by this COVID-19 pandemics, who to help or not. So what, when, and how we should apply this help and treatment, how to teach and train lay people, how to teach and train medical professionals, what we can consider as safe now. These are just really a few of the questions, and I am looking forward, and I believe that our discussion points tonight will need to provide some insights and some answers for the so many challenges and questions around us. So, ladies and gentlemen, let the panel begin. Thank you very much. And Leo, I would love to ask for your presentation, please, about the ethical challenges what we are facing nowadays.
We'll see what I can do. Okay, thank you, Violetta. Thank you for your very kind words of introduction. And dear virtual 700 friends around the world, I'm most grateful to Violetta and to the Serbian Resuscitation Council for giving me the opportunity to participate in this remarkable panel discussion and to share with you some of my thoughts about the impact of the COVID-19 pandemic on our ethical practices. As you can see, I could not find a good picture of Violetta and me together on one photo. Usually there was one or more persons in between the two of us, but I promise we will try to work on it on the next opportunity. Anyhow, I take this opportunity to personally thank and congratulate Violetta and also her team for this remarkable achievement. And allow me to give you, dear Violetta, a big virtual hug and a warm virtual applause. In the 2015 ERC guidelines, I had the privilege to take the lead in the chapter on ethics. In 2015, the pendulum of care was shifted from the traditional doctor-centered care towards the modern patient-centered care. Autonomy versus paternalism. Autonomy instead of paternalism. As a consequence, much attention was given to introduce the concept of shared decision-making in advanced directives advanced care planning, and DNR decisions. And the implementation of these principles was done in the specific European context, which is characterized by a high variability of legislations, cultures, and organizations. Also, better prognostication was helpful for tailoring the criteria for withholding or withdrawing CPR. In 2015, the overall tenor was good quality CPR for all. That means to start CPR in the absence of a clear contraindication, but to reconsider the situation as soon as possible. For the 2020 ERC guidelines, Spiros Mentzelopoulos has taken the lead. Thank you so much, Spiros. Much of the 2015 guidelines remain valid, but several aspects are now supported by evidence. And yes, we are well underway towards evidence-based ethical guidelines. This is great. The pendulum of care came back to a balanced integration of patient-centered autonomy with doctor-centered knowledge. This balance, autonomy and paternal, they are not enemies. Autonomy and paternalism are not antagonists. And this balance is approached. This is now supported by scientific evidence from quantitative and qualitative studies, including prognostication and application of TOR, termination of resuscitation rules. Again, the implementation of these principles has to be tailored to the European context with its variable local legislation, culture, and organization. Also, in the new 2020 guidelines, much attention is given to the shared responsibility of patients, family, and healthcare professionals in planning the future care. The slogan of 2015, CPR for all, was adjusted, was corrected into a slogan, CPR for all who need it, taking into account the conditional balance between potential benefit versus potential harm. And in view of the aspect non-maleficence, much attention is given to safety. Safety of the patient, safety of the healthcare professional, and safety of the society. And the work of these 2020 guidelines was progressing very well, and early this year the manuscript was more or less ready for being submitted. But all of a sudden, we were overwhelmed by a tsunami. An unknown, highly infectious and highly lethal SARS-CoV-2 virus with no cure, no vaccine, that covered the whole world in a very few weeks' time with an unstoppable pandemic of the COVID-19 disease. And as per today, this pandemic is responsible for more than 5.7 million confirmed infections, with more than 100,000 new cases per day worldwide, killing more than 357,000 people worldwide. And in Belgium, with a population of only 11 million, we have more than 10,000 patients who died. Societal and commercial activity was completely paralyzed. Schools closed, shops closed, borders closed. And in a short time, we learned to adopt the lockdown measures with social distancing, hand washing, and mouth masks. The measures for the 70+ category, and I can tell you, these measures were very rigid and were very confronting. Hospitals were overwhelmed. ICUs were overwhelmed. The whole healthcare system was overwhelmed. And there was a shortage of protective devices, of ventilators and personnel. But above all, we are dominated by fear, a fear for the unknown and fear for what has to come. With Europe being in the eye of the storm of the COVID-19 pandemic, it was the general feeling that today our ERC community has a higher need for clear, up-to-date guidelines specifically focused at the COVID-19 situation. And therefore, the publication of the full ERC guidelines was postponed to early 2021. And these 21 guidelines will include appropriate reference to the COVID situation. We needed specifically focused COVID-19 guidelines. And Koen and Jerry have managed in a very short time to coordinate 8 writing teams, resulting in the production of dedicated ERC COVID-19 guidelines. Thank you so much, Koen and Jerry. And now you can find the 8 chapters of these comprehensive COVID guidelines on the ERC website, and probably you have already seen and found them. For the chapter on ethics in this COVID guidelines, Patrick van der Voorde was prepared to take the lead. Thank you so much, Patrick. And I'm happy to guide you through the key messages of the COVID ethics chapter. And you can find the key messages on the infographic that accompanies these guidelines on the ERC website. First, these dedicated guidelines need to be seen in the right context. We deal with an unknown but very contagious and lethal virus. There are different levels of prevalence of COVID-19 in the European countries. And within the European countries, there is a high variability of law, organization, and culture. Also, many things remain unchanged, be it with some specific accents imposed by the current situation. And in an average, the 2015 guidelines remain valid. And there remains much focus on the balance between benefit and harm. Benefit for the patient, potential benefit for the patient, potential harm for the patient, potential harm for the rescuer. Important is that critical decisions should not be taken by a single person, but can better be achieved by shared decision-making. And finally, shared responsabilization of patients and healthcare professionals can be achieved by promoting advanced care directives and advanced care planning. And there are some aspects that are specific for this pandemic. Safety first. Safety of patients, of healthcare professionals, of society. And we know how to do it. We have our recommendations by the World Health Organizations, and also ILCOR has provided us with some good evidence on how to do, act. Second, if choices have to be made, we have to see what intervention can give most benefit for most patients. And that is what we call distributive justice. We have to remind that the situation is totally unknown. WHO gives us some information, ILCOR gives us some information, and in the past 2 months, there has been an avalanche of publications, good and bad, in the scientific literature. And probably Bernd will tell us some more about this in a couple of minutes. In summary, these ethical guidelines need to be applied in the correct context. Temporary, variable impact in variable countries, and CPR is conditional. CPR will be provided if there is a good balance between benefit and harm. Most of the 2015 guidelines remain valid. Balance between harm and benefit, best CPR for all who need it, shared responsibility, advanced directives, and advanced care planning. And when decisions have to be made, it has to be shared with the team. Some specific COVID aspects are safety first, distributive justice in case of shortage, and we have to remind that we are fighting an unknown enemy. Hopefully, we will not be confronted with the need for making choices, dramatic choices, such as in CBRN disasters, which may confront our duty to help according to our oath of Hippocrates, with the duty, on the other hand, to triage between life and death. My age category may have different views as compared to younger generations in this very difficult choice and dilemma. This may possibly become apparent in the discussion. In many European countries, but not in all, the peak of the pandemic seems to be behind us. We can see this on the cumulative graph for Europe. However, this is not the case for the Americas, and this is not the case for Africa. And we are afraid what will happen there in the weeks and months to come. And we should not forget that the pandemic is not over yet. Today, in Belgium, there are still more than 200 new confirmed infections per day. And there are still more than 200 COVID patients on a respirator in our 1,700 CCO beds. And in fact, we do not know what has to come. Will it be a bright sky at the end of the road? Or will it be a new wave at the end of this road? Probably we will be back to normal once there is a good vaccine. Our children and grandchildren have easily adjusted to the new normal at home and in their schools. We, the vulnerable elderly, the situation is more confronting, I can tell you. But we have also adjusted in our garden and at the seaside. I know, as a vulnerable person, I am biased and I have absolutely no good idea of what is really happening inside the emergency system and inside the hospitals. Therefore, I'm most interested to hear from the real-life experiences of the healthcare professionals from around Europe. And I thank you for your attention.
Thank you very much, Leo, for the brilliant presentation and introduction of the ethical concerns, challenges, facts, what are around us. And I would open our discussion on this point, if you all agree on that. Shule, I think you mentioned you have some interesting highlights from Turkey. Would you share it with us? The microphone, please.
Thank you, Violetta. Thank you, Leo. I would like to tell some reflections about ethics in Turkey, if you let me, Violetta. First, I would like to thank you and the Resuscitation Council of Serbia for your kind invitation, and I'm happy to see you all fine here. As we all know, most of the ethics titles are generally related to the national laws and the resources of the countries. I want to talk about the examples from Turkey. Regarding CPR, not starting CPR in Turkey is not questionable because it's illegal in my country. This rule also applies for COVID patients. And I think it's time to think about rearrange the laws, including starting CPR, not to start CPR or stop CPR in Turkey. Speaking of stopping CPR, if you face a cardiac arrest, we start CPR and investigate reversible causes. If it's primarily due to respiratory failure of COVID, we know that unfortunately, the patient has less chance for return of spontaneous circulation. After excluding all the causes, if the patient is still in cardiac arrest, we stop. As an ethical perspective, risk to the rescuer is one of the important issues that provides hesitation on doing CPR in Turkey and in all the world. In the first days, all of us were anxious about getting infected due to lack of personal protective equipments and lack of knowledge, but the great effort of government, donation of civil organizations and municipalities supplied enough PPEs for the hospitals. So there had been no big problem. In this period, we had 135 CPRs in my hospital. All the team was aware of the importance of donning PPEs. The result is good, wonderful. There is non-infected staff in Blue Coat team. Otherwise, as it is definitely known that performing CPR is an aerosol generating process, and it will be so risky for the team. Even though prioritization is a controversial title with Hippocratic oath, in pandemics sometimes healthcare providers have to behave so. We feel lucky in Turkey that we had never needed this anywhere. We had enough hospital beds and mechanical ventilators for the patients. Of course, we were so anxious about overwhelming of the hospitals and lack of resources, but approximately 70% of beds were occupied till now. We didn't have to prioritize patients, but we had to, if we had to. That would not be based on their age, gender, etc. We kept in mind that in case of overwhelming or many infected staff, we will also need backup resuscitation team. So therefore, all ERC instructors in Turkey work much on training all healthcare staff on how to perform CPR. Furthermore, with the fear of overwhelming, although it's thought to be unethical, we plan to ventilate 2 patients with 1 ventilator if needed, and we were ready to prepare our operating theaters to be used as ICU beds. Thanks God, we never needed that. Thank you for the opportunity, Violeta.
Thank you very much, Shule. I was just thinking, before your any other reflections, perhaps we should see before our reflections to Leo, the scientific community and perhaps Kuhn, and after that to start to discuss about all the topics, if you all agree. Thank you, Shula, very much for this. But then I would like to ask Bernd to share his thoughts about scientific community, thank you, aspects.
Okay, thank you very much, Violeta and the whole team, and congratulations to what you did already with this virtual Congress in a time where many others are thinking about how to do a virtual conference. You are just doing it. So congratulations for that. I have 10 minutes, and what I will present in these 10 minutes has something to do with science, but it also has something to do with subjective and maybe sometimes also provocative thoughts. And I would like to invite you all to participate, and maybe we can have some discussions later on this. And first of all, I would like to start with a very amazing video. You will immediately see from where. This is from the time before COVID, when the world was more or less in good shape with regard to this. And I would like to start with it, and I would like to also transmit the audio, but it will have some recalling, so please don't please stay calm. It is just for one few seconds, and I will now start.
It only takes 2 hands to save a life.
So was it understandable?
Yep.
Okay, you can see none of these young people have a mask or something like this. This was last year in Rio de Janeiro, as you can see. So thoughts from the scientific community side. This already has been mentioned. ERC was working very hard under the leadership of Kuhn and Jerry to come up with ERC COVID-19 guidelines, published on April 24, so just a few weeks ago. We already have several translations into other languages than English. You have seen this slide from Leo. And what is probably important in this, the ERC guidelines reflect also to what has been developed by ILCO before. And the central message is, and this is scientifically proven, that chest compressions and CPR procedures have at least the potential to generate aerosols. Therefore, and for basic life support, it is recommended to do compression-only resuscitation, according to our motto from the World Restart a Heart Day and from the European Restart a Heart Day, where we are saying, check, call, compress is the duty that everyone should do. It is focused here, compression-only CPR, and maybe public access defibrillation, because defibrillation may not cause any general aerosol release. And for children, we all know this is a little bit different, because in asphyctic arrest, you always need breaths to children. So therefore, trained and people who are trained and able to do so may wish to deliver rescue breaths to children. But the world has a little bit changed from recommending lay people also doing ventilation to recommending lay people just doing chest compressions and defibrillation and wait for the ambulance. And this is the picture that we have developed from the German resuscitation country. And you can see here some international guidelines also recommend to have some covering of the nose and mouth of the patient or of the victim, some kind of face mask, if you agree on. And nevertheless, I would like to remind all of us, this is the new chain of survival. And we all know that the first parts are the most important. So changing anything in the attitudes of lay persons towards doing lay CPR may have a huge impact on overall survival. And there are questions that have not been solved scientifically. For example, should the airway be opened initially or not? And I have made, and this is a little bit provocative, and please understand that this is just a subjective calculation. For example, in Germany, we have 70,000 out-of-hospital cardiac arrests per year with a number of inhabitants of 86 million. And we all know that we have 2 to 3 times more survivors with basic life support CPR. So if all Germans would do basic life support, that would mean an additional 10,000 lives saved per year. And now what may change during COVID, and has COVID really an impact? I calculated that an adult in Germany will probably live for 75 years or so, and maybe he or she is starting doing CPR with the age of 14, or if the age of 18 or 19 years, then he or she will have 57 years to find a patient in cardiac arrest, and 57 times 70,000 is about 4 million out of hospital cardiac arrest that someone would have the chance to see on the street or at home. And we all know about 60% of them are witnessed. So that means we would have 2.4 million cardiac arrests over 86 million people who may have the chance to see an out-of-hospital cardiac arrest. And we also know that 60% of this may occur at home. So only in about less than 1 million per 86 million people over a long time period will see an out-of-hospital cardiac arrest in a non-family member, assuming that potential infection in family members is not an issue anymore, in 57 years. And the transmission rate is probably the incidence of COVID-19 in our society during these days is less than 1%. So let's say it is 1%. That means if all would do CPR in the whole community, in 57 years, 9,600 lay people would be infected, which means 168 infected lay people per year. And the COVID-19 death rate, let us calculate this with 5%, and then also calculate a lay CPR rate of 40%. That means in my country with 86 million inhabitants, 3 lay people may die because of BLS and coronavirus transmission during BLS per year. So we also need to face this in comparison to maybe 10,000 lives that could be saved by lay resuscitation. So there is a risk of transfection, but we need to weigh this out. And this is with 86 or 87 million inhabitants per 10 million inhabitants, and this may apply to what we heard from Belgium. They have around plus minus 10 million. This number is 0.3 lay people per year, so the number is really very low. And that is probably also the reason why we in Germany, we have several very critical people saying it is all too much with these measures about COVID. We received major criticism for some of our COVID BLS guidelines because people were accusing us that we were not willing anymore to save lives. So this is just for our discussion later on. And this is Kids Save Lives. We all know this. And we know that Kids Save Lives is a very important issue all over Europe and the world. And how is Kids Save Lives in the future? I'm thankful to Federico for this slide with all the masks in these children. And what about World Restart a Heart Day this year? And the message is e-learning, e-courses. And the World Restart a Heart message will probably be CPR at home, which also fits to reality because 60% of all cardiac arrests occur at home worldwide. Out of hospital increase in Italy, northern Italy, Lombardia during COVID-19, published in the New England Journal as a correspondence. As you can see here, out of hospital cardiac arrests 2020 is the blue bars. And this is out of hospital cardiac arrest 2019. And you can see there is a difference over the days since February 20, when the pandemic hits northern Italy in a very major way. And this is the red line is the number of COVID-19 cases there. So there is an increase in out-of-hospital cardiac arrest, higher incidence of out-of-hospital cardiac arrest, and maybe there is at least a danger, we do not have any data on this, on lower bystander CPR rates, which would have a dramatic influence on overall survival. And just yesterday, you may have probably seen this, out-of-hospital cardiac arrest during the pandemic in Paris in France, published in The Lancet yesterday, more or less the same message. When Paris was locked down, the number of cardiac arrests increased very markedly as compared to all the years before. And the proportion of patients admitted alive to the hospital decreased very markedly during these days. So that has an impact on out-of-hospital cardiac arrest. What about in-hospital cardiac arrest? We have data from Wuhan in China showing that out of 140 patients with in-hospital cardiac arrest, when there's a CPR on the ward, survival is very, very low. So there's just one survivor out of 113 victims. In the ICU, it's a little bit better, 3 survivors out of 23 victims. So these colleagues from China conclude that the overall ROSC and 30-day survival rates of in-hospital cardiac arrest patients with severe COVID was very poor, factors associated with return of spontaneous circulation and 30-day survival were initial rhythm and location of the arrest. So it's better to have an arrest at the intensive care unit, which is an argument for bringing people to the intensive care unit if they need any major medical interventions and have COVID. Advanced life support in adults, we already have heard from Leo that protection is most important for ourselves, for colleagues and bystanders, and for the patient, because we have high transmission rates and deaths in healthcare workers in some countries, in particular, if you don't have any protection equipment. So therefore, we all know, and it has already been mentioned from Turkey, that personal protective equipment is a must. Safe airway management, intubation, ventilation is a must. And many patients, at least in the ICU, are in prone position when they are ventilated because of their ARDS. So we also need to think about CPR in prone position, and this is stated in the ERC ALS guidelines that this is possible. And another thing that has not been mentioned yet, because it was not known until some weeks ago, that is that we also may consider thrombolysis during CPR, maybe more often than we do in a regular case, because we have autopsy findings of venous thromboembolism and pulmonary embolism in patients with COVID-19. As you can see here in these pictures, this is pulmonary embolism. And in this autopsy study, we found venous thromboembolism in 60% and pulmonary embolism in 1/3 of all patients dying due to COVID-19 ARDS and illness. So I think this is also a major important fact. And in these cases, thrombolysis during CPR should be considered. Last not least, personal protection with many different things may have an impact on the quality of CPR. And this is a study from the Polish group out of the ERC Research Network. And as you can see here, if you have this kind of personal protection equipment, the chest compression depth is decreasing already after 1 minute and further decreasing. And the same happens with many other parameters of quality of CPR. So you may change every 1 minute if you have this kind of equipment on the medical staff. As I already mentioned, this is a study coming out of the ERC Research Net. And what about the ERC Research Net? As you can see here, this was again the time before COVID. We have planned to have the ERC Research Net meeting this year in northern Italy at Lago di Guarda. You probably also remember a lot of people here, particularly Federico, who is with us tonight. And unfortunately, we needed to postpone it, but hopefully we have a meeting in 21, again at Lago di Guarda. And with this,
it only takes 2 hands to save a life. It only takes 2 hands to save a life.
And this is also valid during Corona pandemic. So thank you very much for your attention and for this great opportunity. Thank you.
Thank you very much, Bernd, for your wonderful presentation and sharing facts and some thoughts. And I am sure that this is going to generate quite a lot of questions. Thank you very much, Bernd. Unfortunately, Bernd, may I ask you to just, perfect, thank you very much. And I had some messages that the live streaming followers are not able to see the whole screen, but this is an IT issue. It's not up to us. So I would like to ask Kun to share with us your thoughts about from the perspective of the European Resuscitation Council, as unfortunately Professor Xantos excused himself today due to personal reasons. So we are going to talk some next time about CBR and hazmat aspects. Thank you, Kun, please.
Thank you very much, Violetta. Maybe I should expand a little bit on what Leo and Bernd just said about the COVID guidelines, because they were made by experts and clinicians, volunteers from the ERC, and these people were very, very busy with the arrangements for COVID themselves when I asked them if they would be prepared to write these COVID guidelines. So it was an enormous effort, and I'd like to take the opportunity to thank them for joining me in producing the guidelines. As we speak, the ERC has sent out a newsletter to over 100,000 people with short video clips, which are on our YouTube channel. And these video clips are actually the lead authors of every section of the COVID guidelines. And in 5 or 10 minutes, they explain to you the key issues in every section, in every chapter. So I invite all of you to go to the YouTube channel of the ERC. Also, we have produced a handful of videos from the field by people who tell about their experiences, much as we are doing today. So again, this is on the YouTube channel. There is more to come, and last week, with the help of Patrick van der Voorde, we have produced an e-learning module about these new guidelines and new approaches to CPR, BLS, ALS, neonatal life support, pediatric life support, also on ethics. And this is in our virtual learning environment, COSY, and it is entirely free. And I was told that until now, over 6,000 people have found a way to this e-learning module. So again, I invite all of you to find the e-learning on COVID and CPR from the ERC. And it is already in different languages, and there are more languages to come. I'm not sure it's in Serbian yet, but I'm sure it will quite soon. And there's even more to come, because Leo has shown you an infographic, but more infographics are in the queue. And there's also some very helpful updates of the algorithms of CPR, BLS, ALS, pediatrics, neonatal, that are going to be on our website also quite soon in different languages. So again, a very useful resource for all of us in these times. And then within a few weeks, we are planning, following your example, Violetta, to have a webinar on the content of the guidelines, and moreover on how to restart courses, because training remains of the essence. We cannot just stop training. Maybe we stop for a few months, but in some countries it's already allowed to start training, but it needs to be safe, and there are some changes needed. So we will provide some framework for restarting any course in CPR, be it in BLS, ALS, or neonatal, or pediatrics. So look out for that message on the webinar. And there's also a document very much like the guidelines that we will be releasing, and it was produced under the guidance of Tino Graef. Maybe you are wondering what happened with the ERC conference that was planned for October, because every 5 years there is a big guidelines conference, and it won't be happening because the venue, as most of you know, has been turned into a pop-up emergency COVID hospital, and is there for the rest of the year, most likely. So again, we will turn the guidelines conference into a virtual conference, and the guidelines we had anticipated to be ready at this moment have been delayed because of all the COVID crisis. But it is an opportunity, because we will, at the conference, in the virtual conference in October, we will have draft guidelines. So that's an opportunity for a very interesting, hopefully, discussion on the draft guidelines, because public comment is very important these days when you develop guidelines. So we will turn this disadvantage into an opportunity for all of us to discuss draft guidelines, which will then, in the next months, be turned into the final guidelines, which will then be released early 2021. So just to give you some outlook on what is happening inside of the ELC family. The restart of the course is extremely important, and although we are doing everything virtually now, there is no way we can teach all of CPR in a virtual way. So inevitably there will be some hybrid way of teaching CPR, probably a lot in the virtual environment, and the cozy e-learning system of the ELC needs to be further developed to accommodate that bigger chunk of virtual learning, but there will be face-to-face training probably for everybody in some way. Also for the conferences, it's extremely nice to have a virtual conference, but it's even better to have a face-to-face conference, I think. So there will be some joining of those two worlds, the virtual conference world and the face-to-face conference world. We are not sure how and when, but I'm sure that it will happen sometime, hopefully next year. So also for the courses, there will be joining of the virtual learning and the real learning, and those two worlds will meet somewhere to have the best outcome in learning. As some of you have said, and also Bernd in his talk, we are all very concerned about CPR and the future of CPR. Because, for instance, kids that arrest in schools, and we are telling now, be very careful, because they might have COVID, and you might have COVID yourself as a rescuer. But that would mean that the chance of survival will probably be very much reduced. So it is an ethical issue, but it is also a very real issue today. So we need to find ways to overcome that. I've seen the calculations of Bernd, which was very cleverly done, and maybe that gives us some insight about the real risk to rescues, which might actually be very small. So thank you, Bernd, for sharing that calculation with us, because it's really inspiring. And it's probably also for drowning, because drowning is another example of a hypoxic cardiac arrest, and nobody would like to do only chest compression CPR before the arrival of ALS. But the fear is so big currently, and it is probably in a way justified, but we need to find a way not to let these people die. And there is a lot of concern about the current way of thinking. I'm sure for the time being, or the last month, with the crisis and the pandemic and the peak level, it was the right way to do. But surely we need to find ways of a future for CPR, so that we can still save all these lives in the near future. Thank you, Violetta. I think there's probably a lot of room now for discussion, and I'm very much looking forward to that. Thanks.
Thank you very much, Koen, for these, I'm going to use your words, the inspiring thoughts you shared with all of us. And there are so much challenges around us, and not only challenges, but how we should meet all these facts what are around us, and how we are going to adopt ourselves. So please, panelists, welcome to discussions what our three fantastic keynote speakers introduced us. Just unmute yourself, please. Who would like to talk? Any questions to Bernd, Koen? Federico, please.
Thank you to
for nice focus on, I can say, concern for the future. And thank you also to Leo about the balance between ethical issue and so it's very challenging for the future. I'm as you know, I'm a little bit worried about September, what happened in the school. So we need to struggle a lot, reach the consensus. So what we need to recommend in the school for lay person, just in case they have some problem with cardiac arrest in with kids on droning, for example, as suggested by Kuhn. I'm very fear about the potential risk that bystanders don't want to intervene in case of cardiac arrest. This is my comment.
Yeah. Yeah.
Yes, Leo, please.
Yeah, Federico, you are perfectly right. I share your concerns for what has to come. And I totally agree that we need to be prepared for a second wave. That we need to be prepared in several aspects. Not, well, I'm not sure that the main problem will be shortage of equipment, of devices. What we have seen in the past months is a little bit positive. There was a little bit shortage, but reorganization and good management coped with it. But the major problem is that in the second wave, people will probably be reluctant to provide CPR, more reluctant than they were before, and even more reluctant than they were in the first wave. And that is my major concern. Also, as to the calculation of burn, it shows that the fear for transmission or transfection should not be that big, but reality is different. Every patient that develops a cardiac arrest now is a potential COVID patient. We also know that in the 70+ age group, and I'm biased, I have a conflict of interest, yes, in the 70+ age group, the incidence of out-of-hospital cardiac arrest is much higher. The mortality of COVID is much higher, and the chances for survival are much lower. We have to be, well, we shouldn't play games, it is the reality. So how will we face a potential, are we prepared for a possible second wave, and how should we be prepared? These are major challenges that I'm struggling with.
Please, Diana, just unmute microphone. Diana, microphone. I'm sorry, it's out of my hands. Can you unmute your microphone, Diana, if you can hear me?
We cannot hear you, Diana.
Diana, microphone. Zlatko, ajde odmute.
We are trying to unmute her, okay? But it's better for her. You can't do it. You can just ask her to unmute.
Understand? Okay, can you hear me now? I try many times, but I don't know why. I have one question, maybe one concern about training, about evaluation. How we will be able to evaluate our online students. because to perform e-learning, okay, will be possible, and we already did this with our student. But now, for next week, we will start the evaluation for medical student from the 4th years from the University of Iași. And I am very concerned how I will be able to evaluate them. By question, yes, but technical and non-technical skill will be a problem. And I'm not sure that our student from this year will be able to do a CPR, a correct one, not this year, not only for the second wave, but also in the future. Maybe we will have the opportunity to do real training next year, but for this year, I don't know, maybe you have any idea, any suggestion?
Parents, please.
If I may come in here from the educational committee, yeah, the ERC has got very severe concerns about the quality of teaching and the absorbed knowledge what our candidates take home and how they can put it into practice in case of need. I think one of the major points is that in the first instance, basically there were almost all of the courses cancelled before we find the right way to go ahead and continue with delivering the message. Now we are crystallizing out the basic educational possibilities, and still there is an ALS course, for example, which has got face-to-face sessions. Most of the stuff is done on an e-learning basis, but there are practical sessions into it. It is obviously very necessary that all the candidates and the instructors are symptom-free, they are wearing protective equipment, they are keeping themselves to the social distancing rules, but it is still possible to do CPR. As for delivering the technical parameters, it is very helpful if you've got a feedback device which can give you the immediate feedback. As for the rest of it, you just use your usual senses on judging the compression depth and recoiling, for example. What is important though, there are concerns about the efficiency of delivering the message when we are wearing face mask, or especially if somebody is doing CPR with the military style N90 or N95 masks. The communication is extremely difficult. You don't see any facial expressions. And obviously the voice is very much, if not muted, but at least damped to a very high level. And that makes delivering all the comments and understanding what is going on much more difficult. So for that reason, at the moment, basically no instructor courses are running in most of Europe. We are still trying to find a way how to make it happen. But assessing the candidates up to a certain level, it can happen by using the technical feedback devices. Thank you.
Thank you very much, Ferenc, for this reflection. And I have to admit that my colleagues in a team related to this specific situation, we started to test this, how I should phrase it, the remote teaching by using different devices, the feedback devices or the simple accelerometers by an instructor, or at least someone who is behind a computer, but he speaks without mask and can react on it, or something what could be useful to supervise the actual movements supported by the technical device. But this is still still in piloting phase, so we are going to see what results and how we can report on that. If you would agree, I would love to ask Diana to share some more details about her experiences from her region, and then to continue to continue to see how different regions were what different regions were faced to with this situation, and of course keeping in our minds what our great intro keynote speakers shared with us and challenged us by their questions. So Diana, I think you prepared a few slides for us, if I may ask you.
Thank you, Violeta. Thank you for the invitation. I will try to share the screen. Don't know again if it works.
And I hope that our audience can also follow the complete, can see the whole presentation as well.
Okay. Don't know what is, okay.
Perfect.
Okay, thank you. I took from your invitation the local flavor of pandemia, and I try, oh, what has happened, but, and I try to present some aspect from Romania. I look to what Leo presents about Belgium. We are on the other border of European Union, the eastern part, and ex-communist country. This is some figures. The mortality in Romania was 7%, so a little more than 5%. I try to, okay, now it's working, thank you. I'm here in the northeast part of Romania, in the most red area of COVID-19 distribution in Romania. So we call this red part Romanian Lombardia. And we had in our region the most high incidence of COVID cases and mortality as well. And we are the regional center for this area, and we try to cover standing team to help our colleague. Also transfer the patient by helicopter or by ambulance, usually the critical care patient, to Iași and Bucharest. The patient intubate, ventilate, and with a lot of device around them. We are happy that not all our patients survive during transfer, because it was very difficult, and we are prepared also to perform CPR during helicopter transfer. So the deaths in Romania are still on a high level, I think, because everybody who died due to COVID, it's somebody who's somebody else love, so it's still high. And our politics, because we don't have enough beds, intensive care in our intensive care units, we try to stop the pandemic out of hospital, and we had 2 months of state of emergency decided by our president, with totally lockdown in Romania. Starting from 16th of March until 14th of May. About fatality, I already told you 7% of the patient die. The most affected group, of course, the patient age 70 to 79 and 80 to 90. we try to look at pre-hospital emergency medical service to 112 calls, and we can see that in March they decreased with 25%, in April with 37%. Our dispatch, starting from April, they prepared to delivery CPR instruction only with chest compression and defibrillation, and using also telemedicine system as every day. But the people in reality, they don't ask for telephone CPR. Usually they call, and they don't accept telephone CPR in this special condition. We send our emergency team, and when they arrive, nobody perform really chest compression except 2 cases. For health professional, the impact was very high. 1 to over 6 person with infection was from health professional because of shortage of PPA in the first stage of COVID-19 pandemic in Romania. That was in March, because as other country we were not really prepared, and we didn't find enough material on the market, European market, and international market. But we start to use, especially in pre-hospital, more than in hospital, we start to use, and after 2 weeks we had normal situation. We are happy not to have our ICU overcrowded. We have emergency department overcrowded, especially in regional centers and in this northeast region, but not ICU overcrowded. And when we have, especially in our region, we transfer by helicopter, using 2 helicopters maybe in the same day, a big one, a small one, and we try to transfer. And we succeed to transfer in good condition, and we save many lives transferring to regional and national center the patient from county hospital. So another experience is our international experience. We sent 2 teams. The first one in north of Italy to help the colleague from Italy, and another one in Moldavia, Republic of Moldavia, who are not in European Union, but they are our neighbor, and they are in the same situation as the rest of Europe. So we experience CPR not only in Romania, but also in the Republic of Moldavia. And this is a great experience working together, also for cardiac arrest in that part of Europe. We publish our guideline, CPR guideline, few days before ERC. It was a decision of Minister of Internal Affairs. We are happy that our work was the same in the same trend as European work, ERC work, and after we receive the guideline, and I was proud to be part of first aid group who delivery a part of this COVID-19 guidelines. We promote this in a big conference with 1,000 participants, of course, online conference performed by Romanian Society of Cardiology. And it was my pleasure to present the Resuscitation ERC guideline translate in Romanian language for my colleague, not only cardiologist, but also internal medicine specialist and emergency physician. And the last slide, it's about our out of hospital cardiac arrest. Compared with the other country, our number decreased. The patient number of cardiac arrest decreased, the ROSC increased, and the pulmonary was the same compared with last year. Thank you very much.
Thank you very much, Diana. Thank you very much. Yes, some screen share stop, please.
Okay.
The little red thing. If I would, while you are stopping the share, if you could list just two things, what were the biggest challenges in pandemics? Just two.
From my perspective?
Or I will come back to you.
Yes. From my perspective, less number of cardiac arrest in pre-hospital, with better ROSC. I don't know, I don't have yet an explanation. I will look more inside. And the international and HEMS mission, international experience and HEMS missions.
Wonderful. Thank you so much. And this was just a great introduction to Anatoly. As you mentioned, the HEMS. Anatoly, I think, have something interesting to share us from the HEMS perspective and the COVID, which could be interesting for all of us. Thank you, Diana.
Okay, thank you very much, Violeta, for inviting me. And as we discussed yesterday, I managed to edit very short videos from the real life CPRs we had to cope during the pandemics. And I will try to share the screen with you if it's working. I hope you are, you can see that. Is it right? Can you hear me also?
Yep. Excellent.
So, and I will try to comment some real life situations we had to cope. I will stop the videos where needed. So the first thing we had to face was that compared to the hospitals, pre-hospital personnel was always sent to the homes or to the patients that had to be considered potentially infectious. So all of them, there was at that moment no triage unless the medical emergency dispatchers were able to take some information. As Leo raised some concerns about future of the CPR, from our perspective, we did not face any problems with the lay people who were probably so stressed and so surprised by the situations that they just followed instructions from the medical dispatchers. But on the other hand, we are responsible for recommendations just for the medical dispatchers and also for the people who are trained in the courses. And I think that there will be definitely some change in especially those hypoxic cardiac arrest and willingness to give ventilations, although we know that it is not so frequently needed. We also discussed extensively about the employment of first responders. In our region, we are using two systems. One of them is professional first responders, as you could see, the police officers. So we let them to be involved in resuscitations as in the past. But after many discussions, we decided to stop for the period activation of volunteers via mobile application, because we felt that we cannot send these people who usually do not carry AEDs to the homes and to the patients that can potentially infect them without giving them sufficient protective equipment. This case you just see is the case of a young person who had refractory ventricular fibrillation after calling the first ambulance for the chest pain and collapsed just as the ambulance arrived on the scene. Subsequently, physician response car was alerted and a helicopter. After some 5 shocks when the VF was continued. We tried to change our procedure for different PET's position, but after subsequent 2 shocks, there was no change in situation, and the cardiac arrest was still there. So the first problem during the pandemics was that the personnel who is wearing at that time some protective equipment was, for example, not easily able to consult that situation with the cardiac arrest center, because all mobile phones and everything was covered below that. Finally, we decided to go for mechanical CPR and try to transport the patient to the cath lab. And again, all the personnel at the receiving hospital had to be prepared and had to be wearing all those things. You could see a physician wearing also the glasses and the shield, which compared to the hospital, if you get out from the ambulance or the helicopter and go to some colder place like outside, all you see is the foggy glasses, so it doesn't happen actually in the hospital. This is the second situation. This is the multiple trauma patient, where, for example, just need to hear the breathing sounds on both sides is also very difficult, because if any personnel is wearing all those hoods, you actually can just measure EtCO2 and not appropriately check the patient as we were used previously. We were also facing some changes in the practice at the receiving hospital. So normal patients, like patients that were not in life-threatening conditions, were tried at some triage tents before the hospital, but it could not be applied for patients like this who were bleeding and who had to be admitted immediately to some specialized places. And it took much longer time for the teams to get prepared. Surprisingly, the number of resuscitations started during the COVID period was much lower than if compared to the previous years. During the March, it was lower for about 25%. In April, for some 10%, and as well as EMS attended incidents was lower for about 10%, which is clear to me because people were afraid to go to hospital. On the other hand, I cannot explain why there was such a drop in incidents of cardiac arrests, because people usually do not decide when to have it. So maybe that the general lockdown of the country, the fact that people are not so stressed driving to work, driving by car, caused this situation. And also some data from New York showed that there was decreased in incidence of myocardial infarctions. So this is the last case from the last week. You see that our medical personnel is still wearing protective equipment. Now the protection used is lower. And I must say that we managed to protect people by very good collaboration with the health institutions, who gave us every day, at least once, updated list of all positively tested people in the area. So it was uploaded after changes of the software into the dispatch center. So every team who was sent to some address where positive people appeared were warned in advance. What we also faced was the problem with the first patients who appeared in the mountain chalet. And although our medical personnel was quite well trained for such missions, we never trained scenario that the patient appears in the area where no ambulance can go. And it was even in the middle of the night. So we had to cooperate and dress mountain rescue, use snowmobile and all these things. So there were many situations that in the future have to be trained, and which are very specific situations we were never trained for, because we did not expect that, although we had some biohazard teams, but we also thought that there will be 1 or 2 patients, and not that the whole ambulance service will respond to everyone as he's infectious. So that was my main view from the pre-hospital perspective.
Thank you very much, Natalie, for the illustrative and deep insights and the real presentation on a real scale. Then I think Jose is the one who is pretty much involved in the out-of-hospital treatment. Jose, what were the most challenges for you?
Well, I think we had the main thing we have found is that we had to adapt to the COVID. I mean, in the beginning we didn't have enough PPE, so our protocols have to adapt to what we had. As the COVID cases increased, the normal cases, I mean, the time-related pathologies like CVA, STEMIs, etc., dropped down. We weren't receiving the normal calls for the cath lab or whatever. The people stayed at home. Now we are facing cardiac heart attacks from 2 weeks ago with no treatment because they were afraid of calling the emergency system. So they were at home. And as the COVID cases are going down, we are going again up with the normal pathologies. And now we have the same case with the PPEs. Now that we have the PPEs, we have the correct material to protect ourselves, we see that the COVID is going down and we don't need to adapt our protocols to our material, but to the pathology. So we are better protected and we can choose which material we use depending on the symptoms and clinic of the patient. We treat every patient as probable COVID in the beginning, and we adapt the material we use once we make a few questions and see if there's any symptoms COVID related. But the main thing is that our call center had to adapt, had to make protocols to choose which COVID intubated patients should be transferred from one hospital to the other. We had to change all the way we work in all the areas to COVID. And the let me say lucky thing was that when we were overcome with the COVID, the people didn't call for not important things. I mean, of course, every patient is important from a point of view, but the diseases, I think it's the same everywhere. When you go to emergency department, you find that maybe 80%, 50%, 60% could stay at home for a while or go to the GP instead of the emergency department. And now people were aware of the severity of the situation, and they stayed at home. They didn't overload the system, but we had 2 weeks that we were overwhelmed with COVID, and we had to multiply for 3, almost 4 the ICU beds, but not the ICU personnel. Yeah. I mean, we were very, very stressed with that because we needed material we didn't have. We had to choose to whom that material was sent, who could use that material. So we have to establish items to choose which patient had preference to receive that material. It was just for 2 weeks, but we were really overwhelmed with that. And now we are seeing again CVAs, STEMIs. We are transferring from one hospital to the other again, normal pathologists, but we still treat them all as probable COVID positive. Thanks.
Thank you so very much.
Yeah.
Yes, Leo, please.
Yeah, Jose, can you just tell me your feeling? Do you feel better prepared in case there is a second wave now? And then second question is, maybe next year we will have a vaccine. Will that change your approach and your organization?
Well, we will be better prepared because we didn't know what was coming to us in the beginning, and now we know. We have suffered for a month and a half, a very stressed situation, and now we are ready. We have everything ready to the next situation if it comes. And the vaccine will come, but we only have, I think it's a 5% of immunity in our population.
Yeah.
So we are very low immunity now, and that means that the next step could come any time. At the vaccine, if the virus doesn't change, that's one thing we have to see. If it really works for the 3 or 4 viruses we're going around, I think we will keep the protection measures that we are having now. I think many of them we will be forever now. I think it's something we have learned in the hard way, but I think that we won't forget that.
But that is also my feeling. It has changed our life for the future. Not only in practicing medicine, but also in organizing meetings and in doing so many things. It has changed our life.
Thank you, Ferenc. Don't forget your thoughts, please. In the meantime, I would like to welcome Dr. Grace Fombad from United Nations Ethiopia. She joined us recently. Welcome, Grace. She is a medical chief officer at UNECA Addis Ababa, Ethiopia. And one thing I learned already at the time was it seems to be a bit short. And I know that a few of you will need to leave at 9 o'clock, but those who can stay a bit more, not much longer, but a bit more, I would appreciate that if you will agree on that, because we can continue our streaming for at least 15 minutes more. If that is for those who are fine with that, I will be grateful, but of course with all understanding for all of you who should leave at 9 o'clock as it was set. But I'm already aware that we cannot finish this discussion until 9 o'clock. So I apologize for that, but this is our first online meeting, so thank you for the understanding, and welcome, Grace, once again. I would come back to you. Grace, can you hear us? Okay. Ferenc, I'm sure it will be sorted. Ferenc, please.
I just wanted to comment that I am very lucky, probably the luckiest of all of you, because I live in the north of Sweden. So Sweden was affected by Corona approximately 2-3 weeks after Lombardy has really blown off. And then living up in Lapland, we have another 3 weeks after Stockholm. So by the time this epidemic reached the region where I am, basically we have all the messages, all the learning points from Italy, Spain, from all the other countries. We had a very good chance to prepare ourselves. And I'm lucky to say that up here, social distancing is our everyday life from the beginning, which means that basically we have not seen a huge wave coming. and probably we are not going to face a second wave either. So the number of people visiting the emergency unit has reduced remarkably, probably 50 to 75% of our normal patient intake. But for us in the hospital, it's enough to have just a few infection rooms at the emergency department because up to 10 or maximum 15 patients of our daily traffic, patients coming in, is suspected with corona infection. I'm very grateful for this position. We could learn so much from you guys. We take the messages. We have the plan if you need to step up. We've got 2 more steps prepared. But at the moment, even if Sweden has been criticized for not doing the lockdown and keeping everything open, we seems to clear us quite well, especially up here in the north. Okay.
Thank you very much. And the great points. I heard what at one of our ethics writing group discussion when we had one of our co-authors, she said when it was suggested in Sweden the 1.5 meter distance, then she said people were reacting like that close we should be to each other. Sorry, sorry. But I had to share that. Leo, you do remember this discussion. So that was our, but well, safety is a bit different by definition of their friends where you do live. Artyom, it would be nice to hear your thoughts, please.
Yeah, thank you. It's an exciting conference, and first of all, I'm very happy that Professor Böttiger shared the idea of thrombolysis in CPR, and it confirms our idea. Just today at the Institute, we discussed the design of a trial of using thrombolytics, Actilisa, in ICU COVID positive patients, taking into account all these ideas of microclots and microclot associated ideas. So I think that we will learn a lot scientifically in this pandemics. And I would like to share maybe, because our experience is quite similar to all of you guys. You expressed everything already, and the pandemics is very different in our country. It's much more prevalent in Moscow, but in Moscow now it's declining, and we have just 2 or 3 regions where it is still quite strong, but in the majority of the parts of the country it's not so intense. Now it's much better. But my big concern regarding the CPR and the courses, and it's maybe more like a question to all of you. Don't you think that people during this pandemics, especially this year, when we definitely will not have any medicines, and most of them show no efficacy in COVID-19, and we will not have any vaccine, that the people, lay people and doctors will be much more reluctant to the idea of CPR and to taking any CPR courses in general, because it's not really their priority in their clinical practice now. And how shall we manage this reluctance, and to make it more simple, how shall we manage the idea of the ESC courses in general? And so that's a great concern. I'm sure, Violetta, that this is a problem in your country also, and that's very similar in our country, that lay people and doctors, especially ICU doctors, CPR was never a priority for them, and we had always to confirm that it's very important, that the training is really needed. So that's my concern for discussion.
Leo, I know you are going to, or you wanted to reflect, just to come back on this for Serbia, that and as Bernd emphasized, so the huge lockdown in CPR, or the statistics will be very different in countries where lay people's CPR was high. So Netherlands, the northern countries, Belgium, wherever. But in countries, as Artyom mentioned, we are not going to have that significant drop down in CPR because the situation, the datas are like they are, and they are speaking for themselves. So that was just my reflection to what Artyom already emphasized. Sorry, Leo, if I jumped in, please.
No.
Okay. Where we are right now. Walter, I would love to hear just your thoughts related to the teaching.
Well,
where we are there.
We in Belgium, all teaching was stopped at the first day of the lockdown. So actually, there is no any demand of teaching. And one of our reflections are how can we stimulate people again to go to courses of CPR because of the fear to face a victim with suspected COVID, and even as all people say,
excuse me, Walter, can you come a bit closer to the microphone?
Yep.
Sorry to be this direct. Thank you.
Better? Is it this better?
A bit.
Not very much.
Maybe to increase the voice.
Yeah, well, I will. Is that? Can you hear me? So.
Yes.
Vaguely.
Well, I don't know why, because I don't have a microphone because I had to change home. So we are reluctant, the people are reluctant to go to courses. And the only hope we have that some factories, medical societies will stimulate doctors and GPs to go back to courses, because this is part of their job. But on the other hand, we have the problem of the insurance, where they could, when people could say, I have a COVID disease because of your intervention. And it's something we could face. So actually, we hope that we can start courses from 15 June of beginning of July, as the rules and regulations let us to do it. But I don't know if we will have a big success on that. On the other way, we are thinking about virtual learning more and more, and maybe like virtual face-to-face teaching. We're discussing it, and actually we made up some based on the ERC guidelines also, and based on what people may do, lay people and paramedics, to teach them how to work on the field. And this is not only courses, but they have to refresh, and that's one of the objectives we have actually. Okay.
Yeah.
Thank you very much. Sula, you already shared some of the ethical questions after Leo's initial introductory speech. What were the most challenges in your country as highly affected as well?
Thank you, Violetta. Can you see my screen?
Perfect. Thank you.
Okay, thank you. Hello, everyone, once again. I'm grateful for the opportunity, and I would like to express my happiness on the starting slide. Like Ferenc, I think we were a bit lucky in Turkey, because the first declared COVID-19 positive case was in March. This date, being more late than many countries, has given our healthcare system and us enough time for organizational plans. Its figure reveals us total confirmed cases, active cases, and total death numbers reached the plateau in the first week of May, and ICU cases got lower during that time. Recovery is getting higher in Turkey now. During this period, what we did as Turkish Resuscitation Council and what were the challenges? Well, we all were unfamiliar and unexperienced about the pandemic. It sometimes made us feel desperate. Not enough information, no written documents. So we started the job preparing a document for our colleagues' usage for suspected or confirmed COVID-positive patient CPR and Blue Code organization. We spread it by social media and published it in Turkish Resuscitation Councils and Turkish Society of Anesthesiology and Reanimation web pages. It was a breath for us. We also prepared adult and pediatric ALS algorithms in Turkish with the reference of Resuscitation Council of United Kingdom. For lay rescuers, we thought that it would be better to teach by visual and audio documents, and we prepared a video for COVID BLS and published it on YouTube and spread it on social media. And ERC and scientific committee helped us soon and published ERC COVID guideline. We translated it to Turkish. Speaking of the code in Turkey, the call number is the same, again, 22 and 22. We used to run to the cardiac arrest location in that format as the Blue Code team. Now we changed our design for that. It's pretty hard to move and to be active in that clothes. And some of us learned to stand outside of the room just in case. The picture shows details about our pandemic patient, droplet and airborne precaution PPEs. They're all difficult to wear and take time and uncomfortable. It seems to be a challenge for us. Furthermore, to avoid transmission, you should be so careful on donning and also doffing. During the first days of pandemic, almost all first responders in the hospitals were really scaring about virus transmission and hesitated to start CPR before resuscitation team arrival. We as the instructors gave our efforts to train our colleagues on wearing PPEs correctly, being safe, and do accurate in-hospital BLS. Firstly, we thought it will be a problem, but now we passed it through quickly by educations. For the airway management, it will generally be a problem to reach an available video laryngoscope. Besides, it's really expensive and there's none in some hospitals. We looked for a solution and founded a new model of video laryngoscope by using cell phones with an application. By the way, it's really so cost effective. It's almost 50 euros. You see here how we manage endotracheal intubation by homemade video laryngoscope. Now, this is how we defibrillated patients in the wardrooms and ICUs with PPEs. We keep on using TTM for post-resuscitation care. Even though it may be hard to establish with PPEs, we definitely believe its positive effects on good neurologic outcome. And for fever control is a second advantage in COVID patients. Of course, there were also pleasant things happened during this time. On the right picture, you can see a TTM applied survivor who had a cardiac arrest due to cardiac reasons during COVID treatment. Now, the most important thing during this period is CPR trainings, of course. With awareness of changing world due to pandemics, we need to understand our upcoming problem. From now on, most of the things about our responsibilities will be solved by using technology. That may sometimes cause some difficulties, and these are the things which we are not familiar in our daily routine. But in a few days, we saw that everyone adapted themselves for any challenge. It seems that for an unknown time period, we will continue trainings with many different ways of teaching and learning. Now, it's time to plan and concentrate on our courses in new formats. This is just an example for a webinar conference we participated in. Ethics is really a challenging issue as usual, and we talked much on it. We never forgetting that pandemic is not an urgent thing motto. We had the rules for it and applied it that we use anytime. This table is the updated one for Turkey. We have more than 160,000 cases, and unfortunately almost 4,500 deaths till now. It has been a very challenging and exhausting period lately, both mentally and physically.
Yeah.
We worked hard. I'm sure you all share the same feelings with us. I know it will never end, but I feel we are very close to victory. Our task is to raise the quality of life, and our mission is to save lives, as we always do. During this period, I would like to thank you all, CPR authorities and ERC, for precious helps. One more thank to all healthcare providers who work self-sacrificing. Please stay safe and thank you.
Thank you very much, Shula.
Thank you.
Thank you for sharing the reality from your country. And
this is a picture of victory, I think.
Our victory in current situations. Exactly.
Thank you.
Thank you so much. May I ask for the, I love the picture, to stop the screen share, please?
I'm sorry, yeah, I'm sorry.
As I'm sure, Federico, are you still with us?
Yeah.
Yeah, thank you so very much. Italy, we all heard and read what is there, but you are there.
Yeah. Thank you very much again to invite me for this nice webinar. I'm absolutely happy to share some memories from the past and one concern for the future. Can you hear me? Can you see my screen?
Yep.
Excellent.
Okay. So basically, I'm a consultant anesthesia intensive care Maggiore Hospital Bologna. For COVID-19, I was back in intensive care because mainly in the last 2 years I worked on EMS. So these are my memories. 8th of March 2020, Italy locked down. This was my last photo. I can say, like in real life, everything changing. And this was my wife with my daughter in the middle of last day before lockdown. After that, everything changed. We created the second intensive care that became COVID-19 ICU. I spent a lot of time in that ICU, fully equipped with PPE, with respirator, with everything. Very hard work. And at the end of April, we closed the COVID-19 because I can say, finish the high peak of COVID-19 patient. In the meantime, we try to put down some advice through letter to editor published on Resuscitation. We wrote with Tommaso Squizzato, Teresa, and Giuseppe some advice about the fear of performing CPR. And 20th of March, we described the first wave that impact of our dispatch center. We received a lot of on dispatch center because the Ministry of Health said, okay, if you need some information, call, in my region is 118. Call 118 to receive some information. So we receive a lot of calls and not real emergency calls that impact a lot on dispatch center. As you can see, the blue area increased from 1,000 calls to 3,000 calls in 1 week. So we struggle a lot with patient at home because the first message was stay at home. And we struggle a lot because we discovered that a lot of patients deteriorating at home with not a real monitoring. So we send a message in the bottle for international community. Maybe we need to think something that could be useful to monitor a patient directly at home during the pandemic, COVID-19, or maybe for the second wave in October. Maybe we need to create something that can help us to track and trigger the patient directly at home. Finally, one concern for the future, I mentioned before, I'm very, I can say, fear about the bystander CPR rate. We need to find some good recommendation for cardiac arrest in the school, how we can manage, how we can protect bystander, how we can convince bystander to intervene, and how we can reduce the fear. So I'm participate to a nice experience, a ERC COVID-19 guideline. For example, this video from experience from the field. So I think it's very useful to share ideas, experience, and as usual, keep the distance we must is the last mention for you. Thank you very much indeed.
Thank you, great for that. Thank you very much, Federico. Grace, can you hear us? Or can we hear each other, Grace? Unfortunately, Grace, we cannot hear Grace, and I'm not sure that Grace can hear us. And it's already 9:02. I apologize again for the time, but this is how, and I learn at least, or we learn from this about the timing. I was reading in the meantime some questions. We have quite a number of questions, and most of them are about the just related to the COVID-19 guidelines. Is the CPR sufficient? Are we going to change the attitude? How they are going to, CPR going to be applied in pandemics? Some of about the e-learning. Then a few questions about ERC Congress. These are the thematics, what I was able to read right now. And it was, we had a problem that obviously the site or the live streaming link was too occupied because people were complaining that it was difficult to assess. But what I can report that we had the highest number of our visitors was 950. And we have 552 people who are with us from the beginning to this. These were just the details. I'm not sure about how much time we could spend together online right now. Because I would like to ask or to offer the opportunity to come back to the people who sent the questions. I'm going to send them the answer.
Good.
If that sounds all right. Grace, are you with us now? Can you hear us?
Yes. Good evening, everyone.
Good evening to Ethiopia, and thank you for joining us.
Thank you.
Could you briefly share us your the most challenges what you faced related to the pandemics?
Yeah. Thank you, everyone, and sorry for joining late, but I've had a very rough day today, which is not part of the meeting. But yeah, I think the pandemic, although we are still below 1,000 cases, is creating a lot of panic because I've virtually almost just closed down the clinic. Many people are not coming to the clinic, and even the other hospitals in the city, they're having the same effect because everybody is afraid. There's a lot of social distancing. So, so far so good from the UN point of view, but within the community, I also think even the ambulance services are not functioning, except those that are transporting the COVID cases. So I would imagine that many staff members, or not staff because we are dealing with two different populations. Within the UN staff, I can always be called, but from the general public, I would imagine that most medics or paramedics are surely not going to do mouth-to-mouth or even not just mouth-to-mouth, but they're not going to do respiration. They are afraid of doing the aspiration because of lack of equipment. And also, that's one of the things. Most ambulances here do not have the full equipment, and the few that have, they are just afraid of transmitting the virus to other people. So it's a big challenge if somebody was to go into cardiac arrest, and I'm very sure that many would have done so without us knowing, but that is a big challenge. I wonder how many people would even want to do the chest compressions, and we do not have CPAPs anywhere in the country where you can imagine that that is an alternative for chest compressions that are done manually. So it's a big challenge when it comes to other diseases, but so far so good in the sense that the government has managed to limit the number of exposures, and we are doing some kind of door-to-door door-to-door census where a team of volunteers are sent from one house to the other, taking temperature. So anybody with any raised temperature is automatically a suspect until proven otherwise. So in that way, we're managing to control of the virus, but definitely the numbers are going up. We started with 2-3 a day, but of yesterday we had up to 100 a day. Yes, the testing has increased, but also the number of cases are increasing. So we're still on the rising curve. We've not started the descending arm of the curve, and we just pray for the best. Thank you.
Thank you. Thank you very much, Grace, for sharing some different views from a different continent, different environment. That was, I'm grateful that you were able to join us, and I'm very happy. Thank you so much.
Thank you.
Dear panelists, how do you feel about the questions? Should we answer right now some questions, or as I suggested, maybe to go back to those who asked by email, or to reply to them if that's suitable with all of you? And by respecting your time and generosity to extend the meeting for almost 10 minutes, I would like to ask you for your final impressions. Or final questions, final impressions, if that is okay. Jose?
Well, I think regarding the COVID as disease, I think we will manage. But I think that we must change a lot of things regarding how we teach and the recommendations we are going to give to the lay rescuers and our candidates in the future. And thank you to all of you for your comments and a great webinar. Thank you.
Much. Ferenc?
Yeah, I think the situation is a challenge for everyone, but I would call you to take it as an inspiration. I think we are in a unique situation where we are forced to think through what we do, why we do it, and is it the right way to do it. We have an extremely powerful tool in our hands now to change and reform anything about healthcare, education in healthcare. Use this opportunity to think through your routines, see what is there still applicable in this situation, what we can learn from it, we can take it to the days when COVID will be part of our everyday life. That's my message.
Thank you very much. Shula?
Violetta, thank you very much. Before impression, may I ask a question to Cohen? May I? I would like to ask about early warning systems. Do we think adding or additional parameters to add to the early warning system scales for COVID positive or COVID suspected patients?
Was that a question for me, Sula?
Yes, Cohen, please.
Because I actually think that Federico is maybe better placed to say something about early warnings course, because he's in the trial. Although I'm also involved in some of the trials in the early warnings course, I haven't got my my mind around early warnings course for COVID patients, I must say. But maybe Federico, are you in a better place to answer this, if I may?
Yeah, if I may, recently there was published an article in Press and Resuscitation. At the moment, the national early warning score is not, I can say, validated for COVID-19 patients, but a very nice letter to editor from China tried to use news plus age, and they assign 3 points as a weight who are over 65, and they compare the traditional news in comparison to this new news adapted for COVID-19 patient, and they understand that could fit to recognize deterioration. In our proposal is to use news off-label in the field, because news obviously was created in the UK for in-hospital rapid response system. We'll see if in some way could fit for out of hospital. I don't know if I respond to your question, Suli.
Thank you very much. My last impressions is I would like to tell that pandemic is not urgent, and we have to learn to live with the virus. It is COVID or not? And we have to create our protocols for the treatments and way of treatments to ease the struggling. Thank you very much, Violetta.
Thank you very much, Shula. Walter?
Thank you for this meeting. It was very impressive. But I think we learned on the field with the COVID for the advanced care that we will be better prepared for later similar infections, even be it a new wave of COVID, be it another virus. Even a pandemic of influenza could be one of them, and we will be better prepared. What I was thinking, and it was something already said, I think it was about teaching in all advanced and basic courses, that we have to change our way of teaching, adapt, but also propose teaching for BLS, for example, that we have the classical way, and if there is a suspicion of something, what can we do, and teach it in the courses also, so that those people are better prepared and not reluctant to start CPR when needed. Thank you.
Thank you. Thank you very much. Diana?
Thank you very much for this opportunity. A wonderful idea, and I hope to have the opportunity to put together our experience in a scientific way about COVID-19 resuscitation time. Thank you.
Thank you very much. Anatoly?
I'm hoping that we will not face any second wave, and even if it comes, I'm sure that we are definitely much better prepared.
Yeah.
And I can see many positive things on this strange period, especially that the virtual learning will become much more common and effectively used. So Federico will be very happy that even the most conservative teachers will finally use virtual learning methods.
Thank you. Thank you very much. Grace, some final thoughts from your side? Or
yeah, I missed the great opportunity to have shared with everyone, but I hope this a meeting was recorded so I can go through it. But like my colleagues have said, it's always a learning curve for us to have new methods of doing work, even though we're so used to the traditional way. But this is also an eye-opener that we need to think beyond the box and to see how we can still be of service to those we take care of without compromising our own security. And I hope that we will have another opportunity to share the experiences from different parts of the world as you started. And so thank you for the opportunity, and I hope I'll be able to listen to the recording if we had them. Thank you.
Thank you very much, Grace. Well appreciated. Federico?
So thank you very much indeed to Serbian Resuscitation Council. Congratulations to Violetta. It's very nice to share idea and share experience on virtual on this virtual conference. As a positive final comment, I think we need to give some antiviral treatment to against the behavior of citizens. We need to fight against the fear. We need to absolutely give some. It's under the responsibility to European Resuscitation Council to protect the citizen and protect the bystander and protect the patient against the fear, because we need to we have taken the opportunity to give a very big acceleration to innovative approach for training, for clinically, and we need to work all together, because this is a new way to live, unfortunately, and we need to be positive to treat the fear of the worldwide citizen, also healthcare professional. Thank you very much.
Yeah.
Thank you very much, Federico. Bernd, are you still with us?
Yes, I'm here. Can you hear me? I'm in the car in the meantime.
Yes, thank you for staying with us. And final thoughts?
I think my final thoughts are thank you so very much for this conference today, for all the good input and ideas, and for the organization and the participation. And since we are the resuscitation people, we need to tell the world that cardiac arrest is still a much bigger problem than COVID-19 is. And there are many other entities where you can die from, and cardiac arrest is one of the most important. And at least in my country, we have now about 8,500 deaths by COVID-19, and we have 10 times more per year sudden out-of-hospital cardiac arrest. And we need to transport this message to because this is the realistic picture of the reality during these days, and we should work in this direction and together. Thank you.
Thank you very much, Bernd. Koen?
Yeah, Violetta. Normally in a virtual conference, I fall asleep after 30 minutes, but not this one. It was really fantastic. It was colorful. It was inspiring. And you know, the secret, I think, is your team, and especially you. You have been extremely warm and friendly and relaxing. And I think we all felt very much at ease amongst friends, and it was a real pleasure to participate. Thank you very much.
Thank you so much, Koen. Thank you very much. Dear Leo.
Yes, dear Violetta, you have done an amazing job. It is what you have achieved is a lesson for all of us. Anyhow, final comments and ideas about this COVID pandemic situation. We have gone through a very rough period, in fact, in Europe. And this rough period has initiated a fear, even at some moments close to panic. Fear from the civilians, from the healthcare professionals, from the patients, and reluctance to go to a hospital, reluctance to go to a CPR course, of course, reluctance to do CPR. And as Bernd said, and as Federico also said, we need to learn from what has happened and how we can adjust our course system and our approach to cardiac arrest patients. During this period, we will have collected an enormous amount of data, and I really look forward to have a close look at these data and how we can adjust our behavior and our system accordingly. What has surprised me, it was really amazing how our healthcare system in Europe was capable of coping in such a short time with the logistic requirements that were enormous. It has taken only a couple of weeks before every country had found solutions and adjust to the emerging needs. Now we have adjusted from the logistic side. Now we have to adjust from the mental side. This will be a new reality. We have also seen that this period of fear was capable of changing so drastically the human behavior in such a short time. I could not imagine that we are all living at a 1.5 meter distance, that we are covering our mouths, that we do that many things all of a sudden. It will be a new world, and I'm very anxious to see how this new world will develop. Thank you for what you have done, Violetta.
Thank you, dear Leo. Thank you, dear all. And I'm really touched and impressed. And I would like to thank you to the audience who joined us. And I will do my best to provide the answers to your questions. Thank you to the audience who was with us tonight. And again, to all your support who are here, or we are here together tonight for so many years. And with this supernova-like new technologies, what the pandemics brought to us, but to open up quite a new perspective, how we can share our thoughts and to spread messages for some better tomorrow. Thank you so very much for being here with us tonight, and God bless you all. Thank you very much. In touch, and see you at next meetings.
Thank you.
Thank you.
Bye.
Thank you very much.
Bye-bye.
Thank you. Bye.
Bye-bye.
Thank you, thank you, thank you. Bye-bye. All the best.
Good night, everyone.
Good night.
Night.
Bye.